Hi, my name is Yenmi and I'm a pharmacist and I like to talk about all things that are related to medications and health related topics. Today I'll be talking about how we can lower cholesterol without the use of medications, and this is based off of the information that comes from the American Heart Association and the American College of Cardiology, in which they released guidelines this year 2026. With that being said, I'm just going to go ahead and get started. If you learned something today, hit that subscribe button or comment down below. It would mean a lot to me. Thank you. It's important that we encourage children and young adults to incorporate a healthy lifestyle early on in life to make it a habit as an adult. In children and young adults who have persistent dyslipidemia, they are at an increased risk of developing coronary artery disease later on in life. Randomized controlled trials and observational studies have consistently linked healthy eating patterns such as the Mediterranean diet, dietary approaches to stop hypertension diet, and vegetarian diets with improved cardiovascular outcomes. Examples of healthy eating patterns include higher intake of fruits and vegetables, nuts, seeds, fiber-rich foods, fats which are monounsaturated or polyunsaturated. This does not mean saturated fat must be completely eliminated. In patients who are willing and able to substitute saturated fats with unsaturated fats, there is a strong association with reduced LDL cholesterol. It's also important to discuss limiting processed sugar and ultra-processed foods, which can eliminate the benefits seen from substituting saturated fats. Responses to dietary changes vary considerably. Heart-healthy eating patterns generally produce modest reductions in LDL cholesterol, but they provide broader benefits, including supporting a healthy weight and improving blood pressure, glucose control, and overall cardiovascular health. Some individuals, especially those with genetic dyslipidemias, may not achieve sufficient LDL cholesterol reduction through dietary changes alone and may also require medication. I covered the Mediterranean diet in one of my hypertension videos, but I'll briefly review it again. The Mediterranean diet is not a fat-free diet, but it emphasizes replacing saturated fats with healthier unsaturated fats. Monounsaturated fats, or MUFAs, mostly come from extra virgin olive oil, olives, nuts, and other plant oils. Polyunsaturated fats, or PUFAs, come from walnuts, flax seeds, and chia seeds, as well as oily fish. Fruits, vegetables, legumes, and whole grains are the foundation of the diet and are fiber-rich and naturally low in fat. Foods such as yogurt, cheese, poultry, and eggs are consumed, but in moderation. And finally, foods such as processed meats, sweets, and coconut or palm oil are limited. Hypertriglyceridemia is defined as a fasting triglyceride level of 150 milligrams per deciliter or higher, or a non-fasting triglyceride level of 175 or higher. Severe hypertriglyceridemia is defined as a level of 500 milligrams per deciliter or higher. Elevated levels of triglycerides are associated with ASCVD events. For patients with hypertriglyceridemia, the first line of treatment is lifestyle management. In some highly responsive individuals, triglycerides may decrease by more than 70%. For adults with fasting triglycerides between 150 and 499, a diet low in added sugars, refined carbohydrates, and saturated fats while minimizing alcohol is beneficial for lowering triglycerides and ASCVD risk. For triglyceride levels between 500 and 999, these same dietary restrictions apply, but alcohol should be completely avoided. Total fat intake should also be individually restricted to reduce triglycerides and the risk of ASCVD and pancreatitis. At triglyceride levels of 1,000 or higher, preventing pancreatitis becomes the immediate priority. A very low-fat diet is recommended, along with eliminating alcohol and added sugars and limiting refined carbohydrates. These patients should receive individualized guidance from a lipid specialist and a registered dietitian nutritionist. Hypertriglyceridemia is often related to a genetic predisposition, but for those without a genetic triglyceride disorder, should focus on limiting processed carbohydrates. Severe hypertriglyceridemia may result from secondary causes such as uncontrolled diabetes, obesity, hypothyroidism, kidney disease, alcohol use, and certain medications. Adults with hypertriglyceridemia should also be encouraged to complete at least 150 minutes of moderate to vigorous physical activity each week, perform resistance exercise twice weekly, and when appropriate, achieve a 5 to 10% weight reduction. Weight loss is typically associated with a greater reduction in triglyceride and only modest reduction in LDL cholesterol. Because several medications can contribute to elevated triglycerides, it's important to review the patient's medication list. The following are some examples of medications and classes that can contribute to elevated triglycerides. These include oral estrogens, selective estrogen receptor modulators, corticosteroids, certain beta blockers and diuretics, immunosuppressants, atypical antipsychotics, HIV protease inhibitors, retinoids, and certain cancer treatments, as well as bile acid sequestrants. Physical activity is essential for a healthy lifestyle and cardiovascular health. The benefits of physical activity include primary and secondary cardiovascular disease prevention, as well as reductions in all-cause mortality. Patients with dyslipidemia are often less likely to meet the recommended levels of aerobic and resistance training recommended by the guidelines compared to patients without dyslipidemia. A meta-analysis of 148 randomized controlled trials involving adults with dyslipidemia whose status was not specifically reported found statistically significant improvements in lipid levels. Exercise increased HDL cholesterol by an average of 2.11 milligrams per deciliter, reduced LDL cholesterol by 7.22 milligrams per deciliter, and reduced triglycerides by 8.01 milligrams per deciliter. These improvements are also seen in middle-aged and older adults, as well as those with diabetes and obesity. The key recommendation for adults is at least 150 minutes of moderate intensity aerobic physical activity per week, or at least 75 minutes of vigorous intensity aerobic physical activity per week. Aerobic activity should be supplemented with resistance exercise involving the major muscle groups at least 2 days per week. Exercise intensity can be measured by its energy cause, known as metabolic equivalence or METs, or by how difficult the activity feels to the individual. Moderate activity is generally 3 to 5.9 METs, or a perceived effort of 5 to 6 out of 10. Vigorous activity is at least 6 METs, or an effort of 7 to 8 out of 10. The easiest way to convey this intensity information without any device for patients is to use the talk test. During moderate activity, you can talk but not sing. During vigorous activity, you can say only a few words before pausing for a breath. As a general rule, 2 minutes of moderate activity produces roughly the same benefit as 1 minute of vigorous activity, which is why the 150 minutes of moderate and 75-minute vigorous targets are considered equivalent. The guidelines specifically cite a 2017 through 2020 National Health and Nutrition Examination Survey analysis of individuals with ASCVD in which 73% were taking at least one dietary supplement and about 1/5 reported taking a supplement for heart health. There is a perception that dietary supplements are safer than FDA-approved medications, but patients must be informed that supplements require fewer safety, efficacy, and manufacturing quality. Over-the-counter fish oil is a commonly taken supplement by patients because they are under the impression that they lower cholesterol levels. The 2021 American College of Cardiology Expert Consensus Decision Pathway explicitly states that non-prescription fish oil products have not been demonstrated to have cardiovascular outcome benefits and are not recommended for ASCVD risk reduction. It should not be considered interchangeable with prescription omega-3 products, especially icosapent ethyl, whose cardiovascular benefits were demonstrated in selected high-risk patients. The SPORTS trial, which stands for Supplement, Placebo, or Rosuvastatin trial, compared rosuvastatin 5 mg with 6 commonly used dietary supplements and placebo in adults without established atherosclerotic cardiovascular disease. Rosuvastatin reduced LDL cholesterol by about 38% and was superior to every supplement and placebo. None of the supplements, including fish oil, cinnamon, garlic, turmeric, plant sterols, or red yeast rice, significantly lowered LDL cholesterol compared with placebo at the doses studied. At the moment, the use of dietary supplements is not recommended as a strategy to lower LDL cholesterol or triglycerides or to reduce ASCVD risk. And that was your dose for medication education. If you learned something today, hit that subscribe button, leave me a comment down below. It would mean a lot to me. Thank you. Have a great day.